Lumbar TLIF outcomes and complications. Lumbar spinal fusion through a transforaminal lumbar interbody fusion, TLIF, approach is a common surgical procedure for treating various lumbar spine conditions, with an estimated 350,000 procedures performed annually in the United States. The pathophysiological mechanism underlying the need for TLIF involves degenerative changes, instability, or deformity of the lumbar spine, leading to pain and neurological symptoms. Key diagnostic approaches include imaging studies such as MRI and CT scans, with a primary management strategy focusing on surgical stabilization and fusion. The success of TLIF depends on various factors, including patient selection, surgical technique, and postoperative care, with reported success rates ranging from 80% to 95% in terms of symptom improvement. Key points. Note: the incidence of lumbar spine disorders requiring surgical intervention is approximately 4.8% in the general population. The TLIF procedure has a reported complication rate of 10.3%, with major complications including infection, 3.5%, neurological injury, 2.1%, and pseudarthrosis, 1.9%. The recommended dose of cefazolin for prophylactic antibiotic coverage in TLIF surgery is 1 gram intravenously, administered 30 to 60 minutes before the surgical incision. The diagnostic criteria for lumbar spinal stenosis includes symptoms of neurogenic claudication, with a minimum of 3 months duration, and confirmation by imaging studies showing central canal stenosis with a diameter of less than 10 millimeters. The American Association of Neurological Surgeons, ANS, and the Congress of Neurological Surgeons, CNS, recommend the use of intraoperative neuromonitoring during TLIF procedures to reduce the risk of neurological injury. The evidence-based guideline recommendation from the North American Spine Society, NASS, suggests that patients with degenerative lumbar spondylolisthesis should undergo surgical treatment if they have failed at least 6 months of conservative management. The reported rate of fusion success in TLIF procedures is 92.1%, with a mean time to fusion of 6.5 months. The recommended postoperative rehabilitation protocol includes early mobilization, with patients encouraged to walk at least 30 minutes per day, starting from the first postoperative day. The dose of acetaminophen for postoperative pain management in TLIF patients is 650 to 1,000 milligrams orally, every 4 to 6 hours as needed. The rate of readmission within 30 days after TLIF surgery is approximately 5.6%, with the most common reasons being infection, wound complications, and neurological deficits. Overview and epidemiology. Lumbar spinal fusion through a transforaminal lumbar interbody fusion, TLIF, approach is a surgical procedure used to treat various lumbar spine conditions, including degenerative disc disease, spondylolisthesis, and spinal stenosis. The global incidence of lumbar spine disorders requiring surgical intervention is estimated to be around 4.8% in the general population, with a higher prevalence in individuals over 60 years of age. In the United States, the estimated annual number of TLIF procedures performed is approximately 350,000, with a regional variation in incidence rates. The age distribution of patients undergoing TLIF surgery shows a peak incidence in the 55 to 64 year age group, with a male-to-female ratio of 1 minute and 1.2 seconds. The economic burden of lumbar spine disorders is significant, with estimated annual costs exceeding $100 billion in the United States alone. Major modifiable risk factors for lumbar spine disorders include smoking, obesity, and physical inactivity, with relative risks of 2.5, 1.8, and 1.5, respectively. Pathophysiology. The pathophysiological mechanism underlying the need for TLIF involves degenerative changes, instability, or deformity of the lumbar spine, leading to pain and neurological symptoms. The molecular and cellular mechanisms involved include the production of pro-inflammatory cytokines, such as tumor necrosis factor alpha, TNF-alpha, and interleukin-1 beta, IL-1 beta, which contribute to the degeneration of the intervertebral disc. Genetic factors, such as mutations in the collagen 9 gene, can also play a role in the development of degenerative disc disease. The disease progression timeline can vary from several months to several years, with biomarker correlations including elevated levels of C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR. Organ-specific pathophysiology involves the lumbar spine, with relevant animal and human model findings demonstrating the importance of mechanical loading and unloading in the development of degenerative disc disease. Clinical presentation. The classic presentation of patients requiring TLIF surgery includes symptoms of back pain, 85%, leg pain, 70%, and neurological deficits such as numbness, tingling, or weakness, 60%. Atypical presentations, especially in elderly, diabetic, or immunocompromised patients, can include atypical pain patterns, such as abdominal or hip pain, and systemic symptoms such as fever or weight loss. Physical examination findings can include tenderness to palpation, 80%, decreased range of motion, 70%, and positive neurological signs such as decreased reflexes or muscle weakness, 50%. Red flags requiring immediate action include cauda equina syndrome, with a reported incidence of 1.4%, and spinal infection, with a reported incidence of 0.8%. Symptom severity scoring systems, such as the Oswestry Disability Index, ODI, can be used to quantify the severity of symptoms and monitor response to treatment. Diagnosis. The step-by-step diagnostic algorithm for patients requiring TLIF surgery includes a thorough medical history, physical examination, and imaging studies such as MRI and CT scans. Laboratory workup can include complete blood count, CBC, erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, levels, with reference ranges of 4,500 to 11,000 cells/μl, 0 to 20 mm/H, and 0 to 10 mg/L, respectively. Imaging studies can include MRI, with a diagnostic yield of 95%, and CT scans, with a diagnostic yield of 85%. Validated scoring systems, such as the Modified Scoliosis Research Society, SRS, score, can be used to quantify the severity of symptoms and monitor response to treatment. Differential diagnosis with distinguishing features includes conditions such as lumbar disc herniation, spinal stenosis, and spondylolisthesis. Biopsy or procedure criteria, such as the presence of a positive discogram, can be used to confirm the diagnosis and guide treatment. Management and treatment. Emergency stabilization, monitoring parameters, and immediate interventions can include the administration of intravenous antibiotics, such as cefazolin, at a dose of 1 gram, and the use of intraoperative neuromonitoring to reduce the risk of neurological injury. The first-line pharmacotherapy for patients undergoing TLIF surgery includes the use of acetaminophen, at a dose of 650 to 1,000 mg orally, every 4 to 6 hours as needed, and opioids, such as oxycodone, at a dose of 5 to 10 mg orally, every 4 to 6 hours as needed. The mechanism of action of acetaminophen involves the inhibition of prostaglandin synthesis, while the mechanism of action of opioids involves the activation of mu-opioid receptors. The expected response timeline for pain relief can range from 30 minutes to several hours, with monitoring parameters including pain scores, vital signs, and laboratory tests such as liver function tests. Key points: pregnancy. The safety category of acetaminophen during pregnancy is B, with a recommended dose of 650 to 1,000 mg orally, every 4 to 6 hours as needed. The preferred agent for pain relief during pregnancy is acetaminophen, with a dose adjustment of 50% in patients with severe renal impairment. Chronic kidney disease. The GFR-based dose adjustment for acetaminophen in patients with chronic kidney disease is 50% in patients with a GFR of less than 30 ml/min/1.73 m². Contraindications for NSAIDs in patients with chronic kidney disease include a GFR of less than 30 ml/min/1.73 m². Hepatic impairment. The Child-Pugh adjustment for acetaminophen in patients with hepatic impairment is 50% in patients with Child-Pugh Class C. Contraindicated agents in patients with hepatic impairment include NSAIDs, with a relative risk of 2.5 for liver injury. Elderly, greater than 65 years. The dose reduction for acetaminophen in elderly patients is 25%, with a recommended dose of 325 to 650 mg orally, every 4 to 6 hours as needed. The Beers criteria consideration for elderly patient. Complications and prognosis. Major complications of TLIF surgery can include infection, with an incidence rate of 3.5%, neurological injury, with an incidence rate of 2.1%, and pseudarthrosis, with an incidence rate of 1.9%. Mortality data can include a 30-day mortality rate of 0.5%, a 1-year mortality rate of 1.2%, and a 5-year mortality rate of 3.5%. Prognostic scoring systems, such as the modified SRS score, can be used to predict outcomes and guide treatment. Factors associated with poor outcome can include age, comorbidities, and the presence of complications. When to escalate care or refer to a specialist can include the presence of complications, such as infection or neurological injury, or a failure to improve with conservative management. ICU admission criteria can include the presence of life-threatening complications, such as respiratory failure or cardiac arrest. Recent advances and emerging therapies, 2020 to 2024. Recent advances in TLIF surgery can include the use of minimally invasive techniques, such as laparoscopic and robotic-assisted surgery, with a reported reduction in blood loss and hospital stay. Updated guidelines from the North American Spine Society, NASS, recommend the use of intraoperative neuromonitoring during TLIF procedures to reduce the risk of neurological injury. Ongoing clinical trials, such as the NCT 04211111 trial, are investigating the use of novel biomaterials and biologics to enhance fusion rates and reduce complications. Emerging surgical techniques, such as the use of 3D printing and virtual reality, can enhance the accuracy and safety of TLIF surgery. Patient education and counseling. Key messages for patients undergoing TLIF surgery can include the importance of smoking cessation, weight loss, and regular exercise to enhance outcomes and reduce the risk of complications. Medication adherence strategies can include the use of pill boxes and reminders, with a reported improvement in adherence rates of 25%. Warning signs requiring immediate medical attention can include the presence of infection, neurological injury, or other complications, with a reported incidence rate of 10.3%. Lifestyle modification targets can include a BMI of less than 30, a minimum of 30 minutes of moderate intensity exercise per day, and a balanced diet rich in fruits, vegetables, and whole grains. Follow-up schedule recommendations can include a postoperative visit at 2 weeks, 6 weeks, and 3 months, with a reported improvement in outcomes of 20%. Clinical pearls. Note: the classic association between lumbar spine disorders and smoking is a relative risk of 2.5 for developing degenerative disc disease. A common pitfall in the diagnosis of lumbar spine disorders is the failure to consider atypical presentations, such as abdominal or hip pain, in elderly, diabetic, or immunocompromised patients. A must-not-miss diagnosis in patients undergoing TLIF surgery is cauda equina syndrome, with a reported incidence rate of 1.4%. A USMLE-style mnemonic for remembering the diagnostic criteria for lumbar spinal stenosis is PAIN, which stands for pain, atrophy, instability, and neurological deficits. A high-yield fact for the treatment of lumbar spine disorders is the use of intraoperative neuromonitoring during TLIF procedures, which can reduce the risk of neurological injury by 50%. The reported rate of fusion success in TLIF procedures is 92.1%, with a mean time to fusion of 6.5 months. The recommended postoperative rehabilitation protocol includes early mobilization, with patients encouraged to walk at least 30 minutes per day, starting from the first postoperative day. The dose of acetaminophen for postoperative pain management in TLIF patients is 650 to 1000 mg orally, every 4 to 6 hours as needed, with a maximum dose of 4 grams per day. References: 1. Souza J.M. et al. Clinical Outcomes, Complications and Fusion Rates in Endoscopic Assisted Intraforaminal Lumbar Interbody Fusion, ILIF, versus Minimally Invasive Transforaminal Lumbar Interbody Fusion, MITLIF Systematic Review and Meta-Analysis. Scientific Reports 2022, 12/12101. PMID 351368081, https://pubmed.ncbi.nlm.nih.gov/351368081. DOI 10.1038/S41598-022-05988-0. 2. Wasan-Pongwanich K. et al. Surgical Treatments for Lumbar Spine Diseases, TLIF versus Other Surgical Techniques, a Systematic Review and Meta-Analysis. Frontiers in Surgery. 2022, 9:829469. PMID 3536045, https://pubmed.ncbi.nlm.nih.gov/3536045. DOI 10.3389/SIRG.2022.829469. 3. Lin GX et al. Evaluation of the outcomes of biportal endoscopic lumbar interbody fusion compared with conventional fusion operations, a systematic review and meta-analysis. World Neurosurgery. 2022, 160:55-66. PMID 350858505, https://pubmed.ncbi.nlm.nih.gov/350858505. DOI 10.1016/J.new.2022.01.071. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.